Good day to everyone. First of all, I want to thank the Philippine Urological Association Mindanao Chapter with their course director, Dr. Nimrod Sarasa, for the invitation to be part of their first online postgraduate course. So we are tasked to provide learning hacks to simplify and cater the needs of patients in a low resource setting from the subspecialty of male infertility. The standard practice of male infertility requires affiliation to a fertility clinic and IVF center. If you don't have the setup, it is important to know when to refer to this specialized center. So some of the treatment options for male infertility might require assisted reproduction, which might not be in congruence with your religious belief. But for the sake of discussion, we will be talking about this treatment option. Remember that management of infertile men starts in the clinic and not in the operating room, meaning surgery is not always a treatment for these men with poor reproductive potential. For your practice, I recommend you to use these guidelines from the American Urological Association, American Society for Reproductive Medicine, and European Association of Urology. They have good summaries on how to treat and manage men with infertility problems. This can also serve as a guide to your male infertility practice. Basically, infertility is defined as the failure to achieve clinical pregnancy after 1 year of regular, unprotected sexual intercourse. Minimum initial evaluation includes a good reproductive history and at least one semen analysis. If these reveal abnormal results, a second semen sample is required for evaluation and some additional tests, like the hormones, genetic testing, and imaging of the male reproductive tract. So I personally made this evaluation form for my patients in order to help me not miss any single detail, which might be very relevant to the cause of their infertility. Okay, you can make your own evaluation form that can assist you in your investigation of the etiologies of your patients. So this form includes the infertility history, childhood and development, gonadotoxin exposure, medication history, and also the personal history, sexual history, family history, and previous surgeries. So relevant details should not be neglected because this might be the only key for a successful pregnancy. This is also my personal patient's record. Again, you can make your own chart for your patients. So this includes the semen analysis results. For me, the most important parameters are the volume, the pH, the sperm concentration, motility, and morphology. Then the physical examination, assessment, and plan. So physical examination should focus on the genitalia, the measurement and consistency of both testes, presence and consistency of the vas deferens and the epididymis, the presence of varicocele, presence or absence of secondary sexual characteristics, and digital rectal examination. So I recommend you to use an orchidometer or a caliper to get an estimation of the size of the testis. I personally use an orchidometer in my practice. So less than 15 ml is considered small testis. So color red beads are considered normal sizes. So hormonal testing is indicated in men with sperm concentration less than 10 million per ml and to those with sexual dysfunction. It is very important to do a detailed history, extensive physical examination, and hormone profile because by this you can differentiate between obstructive with non-obstructive azoospermia in about 89 to 96% of the time. So genetic testing is indicated in men with sperm concentration less than 5 million per ml and in men with non-obstructive azoospermia secondary to testicular failure. Ideally, karyotyping and Y chromosome microdeletion should be requested, but in most of the local setting, karyotyping is only available. And always consider the age of the female partner in offering treatment options for these infertile couples. You may offer surgery in men with younger female partner and assisted reproduction in men with an older female partner. So etiologies of male infertility range from congenital to acquired causes. Despite of any effort to determine the possible underlying causes of male infertility, about 30% of them will remain undiagnosed, hence the term idiopathic. And there are some with normal semen parameters that will remain infertile in about 30% of cases, hence the term unexplained infertility. And these infertile men with idiopathic causes are usually left to choose between assisted reproduction or empiric medical therapy. The European Academy of Andrology published a guideline on management of infertile men with idiopathic causes. So empiric medical treatment for idiopathic male infertility is considered as off-label treatment. You can give antioxidants, follicle-stimulating hormone, anti-estrogens, and remember, testosterone is contraindicated in men desiring to be a father and should not be given to them. Antioxidants are one of the most commonly given medications in male infertility. So based on the recent Cochrane database of systematic reviews on the use of antioxidants for male infertility, use of antioxidants is associated with significantly increased clinical pregnancy rate and live birth rate, and significantly decreased miscarriage rate. Antioxidant use is likewise associated with a significantly lower sperm DNA fragmentation test. If you use the terms antioxidants and male infertility, it will generate more than 1 million results. Because of the availability of these over-the-counter medications, it is prone to discriminate use, leading to antioxidants paradox. Remember that the reactive oxygen species are necessary for normal physiologic sperm functions like the acrosome reaction and capacitation. An excessive use of antioxidants can cause reductive stress, resulting to infertility. This is the most recent systematic review on the different antioxidants on male infertility. The 5 most commonly used ingredients are vitamin E and C, zinc, folic acid, and selenium, whereas the 5 ingredients with most evidences are vitamin E and C, zinc, L-carnitine, and coenzyme Q10. In all, only 22% of ingredients used were found to have published evidence for improvement in semen parameters, and only 17% of ingredients had data published showing a positive result. In contrary to initial beneficial outcomes with antioxidant use, this recent trial showed contrasting results. Males randomly assigned to receive a daily intake of these antioxidants for the duration of 3 to 6 months showed no significant difference in the improvement of sperm concentration, motility, morphology, and sperm DNA fragmentation. Likewise, no significant difference was seen in the live birth rate between the 2 groups. The question now is to give or not to give these antioxidants as the treatment option for men with idiopathic causes of infertility. So we did several studies on the use of antioxidants in the management and treatment of these men with poor reproductive potentials. Yes, antioxidant supplementation is considered as one of the treatment options for managing these infertile cases, and our conclusions are the following. There is a growing evidence on the beneficial effect of antioxidant use, but most of the studies included are of poor methodological quality technique. A well-designed, large randomized placebo-controlled trial should be done in order to arrive to a definite conclusion. So overall, despite of its drawbacks and limitations, antioxidant use is still a valid option for treatment of infertile men. My recommendations: if the patient is already taking antioxidants on consultation, let the patient continue the intake. Make sure you prescribe antioxidants with the most evidence. Next drug is the Clomiphene citrate. So Clomiphene citrate is the most commonly prescribed drug for male infertility. So in this meta-analysis by our very own Dr. Mike PUA, Clomiphene citrate is associated with a significantly increased improvement of the sperm concentration and motility, significant increase in FSH and testosterone, and more importantly, it is associated with a significant increase in pregnancy rate. Important points: you do not give Clomiphene citrate in all infertile men. You only give this drug in men with low testosterone and normal or subnormal LH, regardless of FSH level. You can give 25 milligrams, 1 tablet every other day for 3 months, and repeat the semen parameters analysis. So when do you give aromatase inhibitors? In those men with low testosterone and testosterone estrogen ratio less than 10. So you can give anastrozole 1 milligram per tablet, 1 tablet every other day for 3 months, then repeat semen analysis after 3 months. Again, testosterone is contraindicated in men desiring to have biological children. Yes, initially it will increase the level of your testosterone, but exogenous testosterone will send negative feedback to the pituitary gland and the hypothalamus, thereby shutting down the secretion of your gonadotropins, the FSH and the LH, leading to low testosterone production and abnormal spermatogenesis. In our review on the medical treatment of male infertility, medical treatment for idiopathic causes of male infertility is off-labeled and only indicated for men with hypogonadotropic hypogonadism. Moving on, varicocele is considered as the most common cause of male infertility we encountered in our local setting. This can be seen in 15% in normal male population and 40% in men presenting with infertility. So typical indications for surgical repair of varicoceles are infertility, reduction in the size of the affected testis, and intractable pain. But how about the unusual indications for doing varicocelectomy, specifically in men with varicocele and non-obstructive azoospermia and men with elevated sperm DNA fragmentation? It was estimated that varicocele could be identified in 5 to 10% of patients with non-obstructive azoospermia. In this systematic review and meta-analysis on varicocelectomy in men with non-obstructive azoospermia, doing varicocelectomy will result in the return of sperm in the ejaculate in more than 40% of patients. Compared to azoospermic men without varicocele repair, sperm retrieval rate is significantly higher in men who underwent varicocelectomy. Likewise, it is associated with higher clinical pregnancy rate and higher live birth rate. But make sure you do varicocelectomy only in men with non-obstructive azoospermia, meaning in those men with high FSH, small testes, and flat epididymis, and not in men with obstructive azoospermia. If no pregnancy nor the presence of sperm in the ejaculate after surgical correction of the varicoceles, refer this patient for sperm retrieval in the form of microdissection testicular sperm extraction with IVF. How about the role of varicocelectomy in men with high sperm DNA fragmentation? In a multi-center study by Sandro Esteves, men with leukocytospermia and men with varicoceles had the highest sperm DNA fragmentation level. In 2016, a panel comprised of 5 urologists and 1 andrologist with expertise in male infertility were selected to provide evidence-based recommendation for sperm DNA fragmentation testing. These are the most commonly used tests for sperm DNA fragmentation: the sperm chromatin structure assay, COMET assay, sperm chromatin dispersion test, and the tunnel assay. In our center, we're using the sperm chromatin dispersion test. Sperm with halo is considered normal, while sperm without halo is considered containing fragmented DNA. So DNA fragmentation index of more than 25% is considered as an abnormal result. Based on the teachings of our mentors since residency, men with varicocele with normal semen parameters are not recommended to undergo varicocelectomy. So one of the indications for sperm DNA fragmentation testing is for men with clinical varicoceles. The recommendation, men with low-grade varicoceles with borderline or abnormal semen parameters, and men with high-grade varicocele with normal semen parameters. If their sperm DNA fragmentation testing reveals elevated levels, the recommendation is to do varicocelectomy for this set of patients. So now we can offer varicocele repair even in men with normal semen parameters and elevated DNA fragmentation index, although this is still controversial globally. In a meta-analysis done by Wang et al. On the relationship between varicocele and varicocelectomy and sperm DNA damage, the overall estimates show that patients with varicoceles had significantly higher sperm DNA damage than controls, with a mean difference of 9.84%. And varicocelectomy can improve sperm DNA integrity with a mean difference of 3.37%. In addition, sperm DNA fragmentation is 5-fold lower in testicular sperm than ejaculated sperm. So with that finding, use of testicular sperm for IVF is significantly associated with higher live birth rate and significantly lower miscarriage rate. In this systematic review, testicular sperm is preferred for IVF in men with high sperm DNA fragmentation and severe oligozoospermia. So use of testicular sperm instead of ejaculated sperm in recurrent IVF failure might be an option. Despite these findings, this is still controversial due to lack of low quality evidence available. So the best technique for varicocele is the microsurgical approach. Microsurgical varicocelectomy is significantly associated with increased improvement of the sperm concentration and motility, significantly decreased complication rate and recurrence rate, and more importantly, significantly increased pregnancy rate. I did a survey among urology residents last 2019. About 68% of them are only using surgical loop. So in this study by Sang et al., they compared the intraoperative findings between loop-assisted and microsurgical varicocelectomy. Compared to loop-assisted varicocelectomy, microsurgical varicocelectomy is associated with a significantly higher internal spermatic arteries and lymphatics identified and preserved, and significantly higher internal spermatic veins ligated. Loop-assisted varicocelectomy is associated with higher internal spermatic veins missed. So use of vascular Doppler also improves intraoperative outcomes. I personally use 8 MHz vascular Doppler for varicocelectomy procedures. So use of vascular Dopplers improve the identification and preservation of the blood supply of the testis. Significantly higher veins ligated and significantly higher arteries preserved are associated with vascular Doppler use. So going back to the survey, only 6% had either assisted or performed microsurgical varicocelectomy with intraoperative Doppler. So surgical microscope is not readily available in other hospitals, especially in the province, that can be used for varicocelectomy. Expensive cost is mainly the reason. It is only available in higher and advanced centers. So I look online for cheaper surgical microscope, and I found this portable microscope from Lazada, which only costs 1,000 pesos. So using an application called Camera Fi, which can be downloaded to your phone, it can be connected to your cell phone, laptop, or any monitor. So before the pandemic, we started doing this comparative study on the intraoperative findings between this surgical microscope and portable microscope from Lazada. So we used two monitors side by side to compare the intraoperative capture of both microscopes. So the right monitor is connected to the surgical microscope Leica, and the left monitor is used to transmit the capture from the portable microscope that is wirelessly connected to my cell phone through the app Camera 5, and this is being projected to the left monitor from my cell phone by screen mirroring. These are the images captured by the portable microscope during subinguinal incision, during spermatocord isolation, isolation of the vas deferens, identification of veins, and ligations of the veins. Our preliminary results show the following drawbacks: the stability of the assistant hand while holding the camera, the need for a monitor, sterilization of the camera, difficulty adjusting the brightness, and the main finding, it cannot replace the surgical microscope. You can try it. If it is useful to you, you continue using it. So for me, azoospermia does not equate to infertility. There is still a chance of having a biological children. So non-obstructive azoospermia is more common than obstructive causes. So absence of sperm in the ejaculate does not necessarily mean no sperm within the testes. In fact, if you look inside the testes of men with non-obstructive azoospermia, about 25 to 70% you can find sperm depending on the etiologies. On the other hand, men with obstructive azoospermia, about 100%, you can find sperm on sperm retrieval. I personally made this diagram to easily differentiate obstructive from non-obstructive azoospermia. So men with small testes and high FSH, most likely they have non-obstructive azoospermia. On the other hand, men with normal FSH and enlarged testes, most likely they have obstructive azoospermia. Microtese with IVF is the gold standard for the treatment of men with non-obstructive azoospermia. You can do reconstruction or sperm retrieval with IVF for men with obstructive azoospermia. So when do you do testicular biopsy for men with azoospermia? So you perform biopsy in men with azoospermia, in men with normal sized testes, at least one palpable vas deferens, and a normal serum FSH level. For the reason that men with a histologic finding of non-obstructive azoospermia, specifically maturation arrest, can also present with normal sized testes and normal FSH level. And we do not offer microsurgical reconstruction for men with non-obstructive azoospermia. For men with obvious diagnosis of non-obstructive azoospermia, like in those men with small testes, low testosterone, and high FSH, testis biopsy is not recommended. The ideal setup is a double setup. This is what we do in our center. So tissue extracted will be submitted both for biopsy and to the embryologist. The embryologist will look for sperm, and if there is sperm, we freeze it. If IVF center is not available in your setting, you can still do testicular biopsy in men with azoospermia, normal size testes, and normal FSH level. If biopsy shows normal spermatogenesis, you can do reconstruction or refer to a specialist who can do these microsurgical techniques or for sperm retrieval plus IVF. But if the biopsy shows maturation arrest, refer the patient for sperm retrieval by microtese with IVF. Again, no sperm in the ejaculate does not equate to no pregnancy, and it does not equate to no chance of being a father. So next, the World Health Organization declared the COVID-19 outbreak a global pandemic last March of 2020. So SARS coronavirus 2, which is the causative agent of COVID-19, gain its entry into target cells by the interaction between its virus spike protein and cellular angiotensin converting enzyme 2 and the transmembrane serine protease 2 of the host cells. It was found out that the angiotensin converting enzyme 2 is highly expressed in different tissues, and testis is among the top 5 of those expressions. So the impact of COVID-19 on male infertility is still under study due to the infancy of the reports. The interesting questions are the following. Is the virus present in the semen? Can be this virus transmitted sexually? And what's the effect of this virus on the reproductive potential of men? So initial studies showed absence of sperm in the semen or absence of the virus in the semen. So last May of 2020, the first study reported the first finding of the virus in the semen of men with coronavirus disease. So 6 out of 38 men with COVID-19 had the virus in their semen. 4 of them were during active infection, and 2 of them were on recovery phase. In other study, there is no evidence of sexual transmission of coronavirus. COVID-19 is associated with decreased sperm concentration and motility in men with moderate infection. And men with COVID-19 is associated with lower testosterone level and higher LH and prolactin level. But due to small sample size and short follow-up, no strong conclusion can be made, and still many unanswered questions. Personally, I believe that these can be detected in the semen, the virus can be transmitted sexually, and the virus has a negative effect on male reproductive potential. A proposal by the group of Sandro Esteves was made to prioritize men needing urgent male infertility services during this pandemic. So those men older than 50-year-old who are candidates for assisted reproduction, those men at reproductive age affected by inflammatory diseases, and men with severe male factor infertility under medical or surgical treatment, aiming at improving sperm quality or quantity, and lastly, cancer patients before the initiation of surgical treatment, chemotherapy, or radiotherapy. In these sets of patients, diagnostic semen analysis and sperm cryopreservation should not be delayed and should be prioritized. So for my take-home messages, first is perform good reproductive history and physical examination. You may use male infertility guidelines from the AUA, ASRM, and EAU. You may give antioxidants, give clomiphene citrate in men with low testosterone or subnormal or normal LH, and do not give exogenous testosterone. You may offer varicocelectomy in men with non-obstructive azoospermia and in men with high sperm DNA fragmentation level. Azoospermia does not necessarily mean no chance of being a father. So COVID-19 leaves many unanswered questions, postponing male infertility services like a semen analysis or sperm cryopreservation in these infertile men could compromise the prospect of biological parenthood. So offer treatment option with the most evidence and with the most superior outcomes. And lastly, and more importantly, doctors are only human. So despite all our exhaustive efforts, we cannot diagnose and treat all these male infertility cases. And that is the reality. With that, thank you for listening and keep safe to everyone.